I appreciate your time because I know in Australia it's night time. Thank you so much.
No, thank you, Sama. Again, fantastic talk. Okay.
Pleasure.
Shall we move on now? I'd like to introduce our next speaker, who is Bhawana Purwar. Bhawana is a fantastic colleague. She's a subspecialist trained urogynecologist. She did her medical training at King George's Medical College. She then did her obs and gynae training in the West Midlands before going to do her research in Imperial College London. She did her subspec training in Swansea, so she's moved around a bit. She's now one of our very respected and helpful urogynecology colleagues in the department, and forms part of the team. She's the chair of the British Urogynaecology Society audit meeting, and it's a pleasure in asking you to talk about urodynamics. Bhawana. Bhawana, we can't hear you. You're muted.
I'm just trying to go into the slide share mode. Can you all see my slides? Can you see my slides?
Yeah, we can see them.
Yes.
Yes.
Yes. I can't make it in a slide share mode for some reason. Don't know.
That's fine. It's looking good.
Looking good. Okay, so I'll carry on. Thank you, Sumi. So I'm going to talk about urodynamics. It's a difficult topic, and I will try to keep it as simple as possible. If you want, you can ask questions in between as well. So we all know bladder is an unreliable witness. By that we mean that we cannot always mimic all the pathology even if we do urodynamics. And there has been few studies done. These are old studies I have quoted. But sometimes only 50% of the symptoms of patients will be mimicked in urodynamics. So it's not always 100%. And Powell and et al. Did urodynamics, and they found only 33% of the patients were diagnosed when they had the symptoms of DO, and only 51% in Jarvis and et al. Study. So always we have to keep in perspective patients' clinical symptoms and treat them clinically, and only in specialist cases we go on and do urodynamics, and it's basically to support our management and not replace our clinical discretion. Okay, so as basics, before you go ahead with urodynamics, what you need to do, we do bladder diaries. It gives a lot of information, and most of the time you get a very good idea what you're going to find in urodynamics. It's basically a chart where you can look into their voids, their leakage episodes, and how much they're leaking, the bladder capacity. So if they have very small capacity, likely DO, and you can also get an idea of total urine output as well, and that is an idea how much they're drinking. And you can modify their simple steps. Then you can just say modify their drinks like tea, coffee, or if they're drinking too much water. So that is one of the basics we must do before we proceed to urodynamics. And this will also be helpful in monitoring their symptoms later on if they have some treatment and if they have modified their bladder diaries. Secondly, we must do urine analysis. If they have UTI, whatever medications you're going to give, it's not going to work. So you must rule out any infection before you treat for any overactive bladder symptoms. And again, we need to rule out any retention of urine. So we do post-voice residuals. So usually you ask them to V and then do a quick scan, available in most units. And if they have retention of urine, again, you know that we have to treat the basics before we go on to any medications or any specialized treatment. And if they have significant residuals, then it's likely a bladder obstruction, neurological disease, or retrousal muscle failure. PET testing is not recommended by NICE, but very rarely if a patient is saying that they are continuously leaking urine and we cannot capture any information on urodynamics, then we go on to do PET testing. And we weigh the pads beforehand and weigh it afterwards. Just to give leavage vaginal discharge and all, if we have more than 5 gram weight in per 24 hours, we say it's positive PET test. It does indicate the severity of the symptoms as well and assess their outcome. And where we don't have facility for urodynamics or ambulatory urodynamics, we sometimes need to do PET testing. So this is traditionally how the urodynamics started, and in late 19th century, and they had to have a column of water and measure it. I'm glad that we have modern sophistication now, computers and all, and we have moved to these fantastic machines, and we don't need to do it that way. Okay, so this is one of the setup in Imperial College where I used to work. So our aims is to reproduce patient symptoms and their complaints and get a pathophysiological explanation behind their problems. So get more insight in their problems when we are doing the urodynamics. This is only precise way we can define bladder and urethral function. It helps us to determine their prognosis as well. If they have probably mixed urinary incontinence and we are going to do a procedure, we can always tell them the success rates are not going to be that great because we have found mixed pathology. So it does help it to guide patients, counsel patients beforehand, and also save us in medical legal situation when we have done a surgery and patient have gone back, then we can look into urodynamics. So it does help and complements our practice as well. But as I made a comment before, it must always be interpreted with clinical data and never in isolation. Okay. So before urodynamics, you have to be clear why we are doing urodynamics. Is it going to benefit the patient? Are we not able to diagnose it? Can we just manage with conservative treatments? And did the test likely to reproduce patient symptoms, and what correlation we can do? And then towards the end, if we have multiple problems, we have to pick what is most significant abnormality we had found and which can be treated. Okay, so there are various components of urodynamics. We can choose to do only one or all of them. I'll discuss one by one all of them. So one is uroflowmetry, where we just ask the women to fill up their bladder naturally and be on a special commode and measure the volumes and the flow rate. It helps us to predict if whether there's any obstruction or they can't retain urine at all and they have very small volumes. That means they have problems in storage. So it does help us. And also, if we have done uroflowmetry and they're starting, then we need to look into other pathology like prolapse, where they have significant voiding dysfunction, and simply correcting the prolapse may get rid of the urinary incontinence. And then we move on to cystometry, and which is the bladder pressure studies, where we put the catheter in the bladder and another catheter either in vagina or bladder, and then do pressure studies. Video is complementary. We keep it for specialist cases where the previous surgeries have failed. Then when we do the urodynamics at the same time, we video it. It helps to see any retrograde flow or any, if there's increased pressure in the bladder, you can say you see ureters dilating. And we also see bladder neck descent, and very rarely we can see mesh complications as well. Ambulatory is natural filling. I have got few slides on ambulatory. So we'll talk about that. And urethral function tests we rarely do, but very rarely we have to do these tests as well. Okay. So the NICE recommends that we don't routinely do urodynamics. It's an invasive procedure. It takes 45 minutes to an hour, and it can be uncomfortable to the patient. So we have to have clear indications why we are performing urodynamics. So if they have voiding dysfunction or urological problems, we proceed to do urodynamics. And prior to any surgical treatment, so you have tried all conservative measures, pelvic floor exercises, and nothing has worked, then we go on to do urodynamics. Or you have done previous surgical therapies and they have failed. It's more informative before we do secondary surgery that we do urodynamics. And in overactive bladder, if you have tried all the medications and they're not responding to standard therapy, then we do it before proceeding with Botox, or we are missing something. If they have prolapse, we not routinely perform urodynamics. We tend to correct the prolapse first, especially if it is apical and anterior prolapse, as we know that 50% of the patients will improve. So there's no indication to do urodynamics. First, we correct the prolapse, and then if the symptoms are still persistent, then we do urodynamics. And NICE also recommends that we shouldn't do urodynamics unless we are going towards a surgical route. Okay. Uroflowmetry, we talked a bit about uroflowmetry, where we make the patient V to diagnose any voiding dysfunction. Again, it's important before we do stress urinary incontinence. We know in UK mesh is out now, so either we do Bulkamid or other two operations called suspension or slings. They are major operations, especially slings have issues with voiding dysfunction. So if we know and we see that patients are having intermittent flow or voiding dysfunction, we can tell them, take steps to prevent it, maybe teach them how to do self-catheterization before we do any surgeries. So it does give us useful information. This is how the uroflowmetry looks like. So it's a simple bell-shaped curve. That means it's perfect. And usually if the Q max is the flow rate is more than 15 ml per second, it's likely to be a good flow and unlikely to have any voiding dysfunction. Again, if you have raised detrusor pressure, this will be like patient will be being very quickly and it will go really steep curve, or they will have intermittent curve like this if they have prolapse or any voiding dysfunction. So you can see that they're taking long time. And in some women, they do not generate enough detrusor pressure. So sometimes they contract their pelvic floor to pass urine, which is again intermittent flow. So we know there's some problem with the detrusor. These are specifics you will see when we do urodynamics reporting. What is their average flow rate? Like in this one, Qmax is only 7 ml per second. So it's prolonged flow rate. What is the time taken for the maturation, which is called voiding time, and the flow time, time over which measurable flow actually occurred. Okay. So this is classic example of intermittent flow. So that was prolonged flow. Here the woman is starting, probably using their pelvic floor muscles to pass urine rather than the detrusor pressure. Okay. So basics: rule out UTIs on the day. We do a urine dip test. We pass a thin catheter. The normal filling rate is around 50 ml per minute, but you can modify the rate if the patient is feeling pain, urgency. So we do get bladder pain patients which will not tolerate flow at this rate. So you have to modify your techniques as per the patient. I will not go into the physiology and details, but we tend to zero it to the patient, flush all the lines to take away the air bubbles that it can affect and our urodynamics result. And you must ask patient to cough at regular intervals and see both abdominal line and bladder pressure lines are moving equally. If they're not, you may have to readjust the lines in between, otherwise you will get false results. Okay. So three pressures you basically need to look for basic urodynamics. You don't need to look at any other thing. So intravesical pressure, usually written as PVES. Intra-abdominal pressure, written as P abdomen. And this is the line either put into the vagina or the rectum of the patient. So this is our guide. If patient is coughing, both vesical and abdominal pressure will rise, and we will not get the false reading because when we do the detrusor pressure, we subtract abdominal pressure from vesical pressure. So if both are equally rising, then it will be 0. So I will be showing you some graphs. If you just look at the 3 lines, and you will be able to interpret anything, especially for ST trainees who want to get urodynamics through in their exams. Just look at these 3 lines. Okay. Some standard terminology which we will be using. One is DO, it's called detrusor overactivity. So you will see spontaneous detrusor contraction. It's a urodynamic finding, and we call it DO. Okay, it can be single or there can be multiple contractions throughout the urodynamics. And then conventional one where it takes place in an artificial setting where we are filling the bladder artificially. In ambulatory, we attach the patient with a machine. They can go home, like you do monitors, cardio monitors at home. So similarly, they are given the machine, and when they leak, they just mark their activities. And it is natural, but it's expensive and not used in all the centers. But it just mimics their day-to-day activities, and we are filling the bladder by natural filling, and it's not artificial filling. Okay. Filling cystometry. So it's a method to measure their pressure volume relationship during the controlled settings. And after we have filled the bladder, we ask the patient to void. And that is also important because, again, we will see how they are voiding, as we described earlier, whether they are using bladder muscles, whether they are using pelvic floor, or whether they're retaining and they're not able to pass urine at all. If you fill the bladder too much, then they are not able to pass urine sometimes, and sometimes they double void. So voiding cystometry is also important. Okay. So intravesical pressure, as we said, pressure within the bladder, abdominal pressure, pressure surrounding bladder, rectal or vaginal pressure, which we need to subtract to get the actual detrusor pressure. And once we look at the detrusor pressure, we will be able to diagnose what problem they are having. Okay, so when we start filling the bladder, we mark all these on urodynamics. In a typical urodynamics, you will see when the patient started first feelings. It's not urgency. They just have the sensation that bladder is filling now. And then they get some desire to void, which can be delayed. It's not really strong that they will have to rush to the toilet. So we mark that. It's in a normal patient, it's around 150, 200 ml. You can fill their bladder comfortably. Then they start getting strong desire. At this point, they don't feel they are going to leak, but they have really strong desire, which is usually around 400 ml. And then there's leak point pressure, where if we keep filling them, they were likely to leak. Or if the bladder bladder pressure will start rising, and they will start complaining of pain. If women have reduced bladder sensation, you can fill their bladder up to 800 ml, 900 ml, and they don't feel at all. So we know there's some neurological problem there. And bladder pain we talked about. And urgency is that they have sudden desire to pass urine during the filling phase, which is we mark as urgency, but they're not leaking at this point. Okay. So we talked about normal filling, and if there is no problem in the bladder, you can see that bladder pressure, detrusor pressure doesn't rise at all, and there's hardly any change in the bladder pressure throughout the filling. In detrusor overactivity, you will see detrusor contractions. They can be spontaneous or provoked. By provoked, I mean that they change position or they cough, and then you will see secondary rise. So it's provoked with some event. And then sometimes they may have big detrusor contraction and they may not leak. So it's a finding we just noticed, but sometimes they do leak with the contraction. So then we call it DO incontinence. And phasic DO is when they are having multiple contractions throughout. And terminal DO, that throughout the bladder filling, they did not have any problems. And towards the end, when they reach their full bladder capacity, which we call systometric capacity, they're big contraction. And sometimes it results into complete emptying of the bladder as well. Bladder compliance is the change in the detrusor pressure with the volumes. So usually there shouldn't be any change in the pressure when you are filling the bladder. But if there is poor bladder compliance, you will see as soon as you're starting filling, the bladder pressures will start rising. So that's again pointing more towards overactive bladder. Systometric capacity is the maximum amount they can hold in their bladder. And when the leak during the urodynamic test is called urodynamic stress incontinence. That means they had the symptom, but we sometimes don't see, as we said in urodynamics, that whether they have leaked or not. But if they leak during urodynamics, we call it USI. urodynamic stress incontinence in absence of any detrusor contraction. If there is secondary detrusor contraction, it's called cough-induced DO. So that is likely more towards overactive bladder. If you do any stress incontinence surgery in cough-induced DO, it will be very counteractive. Okay, so some traces. I hope you all can see the traces nicely. I wish I could have gone into the slideshow mode, but somehow I can't.
Yeah, we can see the traces. Yep.
Yeah. Okay. So just basics again. So this is fill cystometry. You can see that this is filling. You can this is the vesical pressure. This is the abdominal pressure line, and this is I can't. I don't know why it's not showing. And this is the detrusor pressure. So so initially you ask the patient to cough, and with the cough you can see the rise there. So there's some dampening in the abdominal pressure line. You can see when they're coughing. I just showed it on purpose that how they can dampen, and it can confuse you. So the pressure is going up to 100 here, but in abdominal line is going up till here. So you're not getting true detrusor pressure there because there's some dampening. So you will get some residual like rise in the detrusor pressure. But throughout the test, you can see that vesical pressure keeps on increasing and abdominal pressure is completely flat here. And when we subtract abdominal pressure from vesical pressure, you still get some rise in the detrusor overactivity. So you can confidently say here that this is detrusor overactivity. You can make a comment that there's some dampening, but still you can see the pressure rise quite nicely there. I hope I have made myself clear. This is the second one. So again, we'll go with the basics. So vesicle line, ideally should be at 0, but +4, -4 is allowed because you can never be perfect in urodynamics. You have to give some leeway. And this is the abdominal line. And here you can see the coughing, the rise is almost equal. And this is when you subtract abdominal pressure from vesical pressure, it's almost 0. This is a nice curve. You can see flat, flat, flat detrusor, and it keeps on. So something happened here. Both of them have gone up. So we have asked the patient to stand up, and that's why the pressure has gone up, or sit up, so it's above the table. But again, you just need to look at detrusor pressure. Do not get confused that, oh, detrusor pressure is rising, because abdominal pressure has also risen and there's perfect subtraction. So as long as detrusor pressure is flat, it's absolutely fine. So this is normal, no rise in detrusor pressure here. Again, this is fill cystometry. So cough, and there's some rise in both abdominal and vesical pressure, and zeroing is nice, no rise in detrusor pressure. So we can confidently say this is a nice curve. But as you move forward, there's some drop in abdominal pressure, so which mimics here that the detrusor pressure is rising while vesical pressure stays there up. So that's what you see when there is poor bladder compliance, that the detrusor pressure starts rising. But I won't be confident here because bladder pressure has gone down, and that some rise in detrusor pressure. Yeah. So, but as we move forward, there is big contraction, and we talked about large contraction in detrusor, while while abdominal line, there's no contraction. So this is DO here, which is causing her problems, and I think she leaked here as well. It says here, you can see in the graph, she leaked. So she had urgency and she leaked here. And just to mention, like we do mark all this. So this is normal desire, strong desire. So, and when she's moving, it's important to mark movements as well, because sometimes the patient is moving and you see, oh, there's rise in detrusor pressure, which can again confuse us. So if in a good urodynamic trace, you should mark any movements, or if they're sitting up, then we know what's happening. Okay. So another fill cystometry, and Again, we have asked patient to cough lots of time, and you can see these spikes, but if you see diffuser pressure remains lovely and beautiful. So there is no diffuser overactivity there. It's a normal bladder, and diffuser has been filling normally. With coughs, there is no activity. So this is again normal urodynamics. Okay. So here, this is vesical pressure, abdominal pressure, diffuser pressure. So we're going to concentrate on diffuser pressure, and as long as we have made sure that zeroing is acceptable. So you can see here abdominal pressure that baseline, slightly raised vesical pressure, but is still acceptable. But when she's coughing, there is some rise. You can see the secondary rise as well. Can you make out the first rises with a cough, and when then the diffuser pressure rises again, the secondary rise. So this is typical cough-induced DO. You will not do, because it says cough and leak, but if you see secondary rise, you will not do any stress incontinence procedure in this patient. You will probably treat her DO at this point. And this is beautiful trace of DO. So again, we'll start with the basics, even if you have spotted. So you will start with the basics, cough, see the zeroing of abdominal and vesical line, and then it's normal, 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 and then there is big rise in diffuser pressure and vesical pressure, while abdominal pressure remains stable. So it's again DO. And another example, I put in lots of traces because you can see there's some background noise in some of them, but you have to just see more and more traces to become familiar with urodynamics. So vesical pressure, abdominal pressure, diffuser pressure. And again, you can see vesical pressure, there's some rise going on there, but diffuser pressure is not rising, so it's normal urodynamics. But towards the end, abdominal pressure looks normal, and there is some rise going on there. So it's again example of DO. Okay. And towards the end, we ask patient to void, and we see how their flow and pattern can be correlated with diffuser pressures. Okay. I won't go into much details of complex urodynamics. I've got only 1 or 2 slides just to show you that what is urethral pressure profile. It's usually done with a subspecialist, but you can see we put a catheter in the bladder, and then we slowly start withdrawing the catheter. So here there is no pressure rise, but as soon as it will hit the urethra, you can see, because urethra is small lumen, the pressure rises, and then you can see the curve. We used to do lots of these when TVTs and TOTs were in place, but we are not doing that many of urethral pressure profile at the minute. And it has its role in very specific circumstances. Okay, and this is how video urodynamics looks like. It's lovely pictures here. You can see there's multiple bladder. This is the diverticulum and trabeculations you can see here. And in this one, you can even see bladder herniation. So it gives us a lot of information, and sometimes you can see retrograde flow into the ureters as well if they have really high pressure, especially in neurological patients. So it does help us to see bladder neck descent and any pathology in the bladder. Again, more specialized tests, so I will not go details of these. And this is how ambulatory kit looks like, and it mimics their natural bladder voiding. And this is a machine we give to them. Okay, move on to, and it's mainly done when we haven't been able to reproduce patient symptoms in normal urodynamics, and patient still complains that they have got symptoms, then we have to go on to do these specialized tests. Okay, few more urodynamics if you still have appetite to carry on with real-time cases here. So this is a case of a 39-year-old lady who had 3 previous cesarean sections. She presented with mixed urinary incontinence, but predominant stress urinary incontinence. Her BMI is 32.9. There's no prolapse on examination, and we have exhausted all the conservative measures, and she's still symptomatic. So we offered her urodynamics. This is one of my colleagues' patients. So this is how a urodynamics request form. So we put in if they have any pessaries or pessary been removed, or if they have need any antibiotics, and whether they are able to stand unaided. So all the information is given in the forms. And then bladder diary, as I said. So it's very crucial. So what is she drinking? She's drinking coffee, but mainly water, which is good. So if we see lots of coffee, 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 we have to go back to bladder training. And this is says here urine passed. So she passed around 150, but then she's passing really small volumes, 20 mil, 20 mil. So they're really small volumes. And then she has said that she had desire to pass urine, and then she's saying strong plus plus strong. So it's all pointing that she has some overactive bladder component. So see how useful it can be. And you can also count the voids she's doing, how many voids she's doing in a day. Again, the second day, we tend to do over 2 to 3 days because one day may not always be representative of her voiding. So she has filled it religiously, which is good. Not all patients do that. And then this is her uroflowmetry, nice bell-shaped curve, no voiding, so it looks good. And then this is our urodynamics here. So filling phase, somehow the top graph and the bottom graph are in one page. Somehow it has come out like in the printout. So again, can you see the graph? So top line is abdominal pressure and vesical pressure, and then detrusor pressure. So we are going to mainly concentrate in these three lines. Mainly detrusor pressures. As soon as you see flat line, you're very happy. There's nothing happening in this lady's pressure, and you can see there's some noise, some movement there, but there's no significant rise. And then towards the end, she has been given permission to void, so she has voided naturally. Again, you can see here she had urgency around 189, so coming up to 200, and she tolerated 318 mil. So overall, I would say not significant, apart from some urgency, stable detrusor throughout the test, normal voiding, and she emptied to completion. So this is her voiding, and there was no retention. So no residual urine, only 7 mil. So this is a normal graph. Again, so normal graph, we can reassure patient and we'll manage her conservatively. And we have here patient-initiated follow-up. So if we give them all the treatment options, and if they're happy, they go home, and they want to contact us, they can feel free to contact us back. So it's patient empowerment rather than we just kind of trying to follow them up. Another case, so this is 43-year-old lady who is para 2, BMI 28.7. Again, she has done all the conservative management medical treatment because she has come with urge predominant mixed UI. We have given overactive medication, overactive bladder medication, anticholinergics, Mirabegron, and everything has failed. So here's Mr. Dasgupta requesting this. So we have given the brief history to our nurses. And then again, bladder diary. So most of the volumes is around 300, 150, 40 mils, and total urine output is around 1850. But she's saying she's leaking. So there's some component of overactive bladder going on there. And second one again, so if you see her bladder capacity is not coming up to 400 mils, she's just passing maximum bladder capacity is 290 here. Again, nice bell-shaped curve, so no voiding dysfunction. And we will just look at the detrusor line again. So this is vesical line, abdominal line, and this is detrusor pressure. So you can see here normal, no rise in pressure, and then this slight rise in pressure there, and then she's carrying on normal, and then again you can see the rise there. I don't know whether you guys can see because quite small, but it says here cough and leak. So she coughed there and she had a bit of leakage. So she's likely mixed urinary incontinence there. So she's a mixed urinary incontinence patient. Okay. Third case, I hope I'm not overrunning. I'm okay with the timing. 2 more cases, I think. 66-year-old lady.
You're fine. Yep.
66-year-old lady. Again, she's presented with stress urinary incontinence. and no prolapse. So we always like to rule out prolapse. And also it's good to do their pelvic floor muscle tone, because if they have stress incontinence, we like to strengthen their pelvic floor before we do anything. So pelvic floor muscle tone is decent, 4 out of 5. And then we offered her conservative measures, which have failed. She filled the bladder diary, and now she's coming for urodynamics. So again, one of my colleagues, Mr. Das Gupta, has requested this. Stress urinary incontinence mainly. She has tried pelvic floor muscle training with continence team. So, and she's very keen for surgical options. There's no point in offering urodynamics if they say they don't want any of the surgical options. You're putting patient to an invasive procedure, which they don't want to pursue them further management. So bell-shaped curve, no voiding dysfunction, which is really important, especially if you're going to offer her SUI surgery, because if she has any voiding dysfunction, we would have taught her stress urinary, self-catheterization. So this is flat line here, vesical pressure, abdominal pressure, and we are mainly interested in detrusor pressure, and flat, flat, flat. So no sign of detrusor overactivity. And then she's coughing, and then she's leaked with the cough here. But in this one, you can see there's some rise, but the rise is same in both of them, and there's no very tiny rise in detrusor pressure there. But not much. So we are confident that this is mainly stress urinary. I would say this, we have to still regard this as tiny rise in detrusor pressure. So I would say as mixed urinary incontinence, but predominantly a urodynamic stress incontinence. Yeah, so same here, mixed DO observed during standing with taps and moderate urinary leakage and coughing. So her overactive bladder symptoms is well controlled with one of the anticholinergics, which is tolterodine here. So once their overactive bladder is well controlled, we are quite happy to offer them stress incontinence surgery. And then we discussed in MDT, and she opted for urethral bulking agent, which is Bulkamid, and we ratified the decision to proceed, and discussed her in MDT, and then we write a letter to the patient. Last case. So this is case 4, 44-year-old lady. So she had Bulkamid in 2019, which worked approximately for 18 months, and now she has come back with recurrence of stress urinary incontinence. Again, we discuss all the options, conservative, medical, surgical, and she wishes to go ahead with surgery. So we booked her for urodynamics, and we give brief history here, the same we talked about, and no prolapse symptoms. Again, nice curve, no voiding dysfunction. And then we can see here that it's completely flat line. So again, vesical pressure, abdominal pressure, detrusor pressure. She's coughing at regular intervals, which is quite reassuring when none of the lines have fallen out. And you can see flat line, completely flat line. So nothing. And then she's coughing, and it's marked here as leak. So no rise in detrusor pressure, but she has leaked with cough. So we are confident she has got urodynamic stress incontinence. And you can see her bladder capacity is quite good as well. We filled her up to 537, which is quite decent amount. And then towards the end, she has voided completely as well. So this is voiding phase. And yeah, so it does confirm stress urinary incontinence, and patient opted for laparoscopic colpos suspension. And that's when we proceeded. Yeah, I think that's the end of my slides. I'm happy to take any questions from the floor. Thank you very much.
Thank you, Bhawana. You could stop sharing. That's fantastic, in-depth overview of urodynamics. Thank you. Really lightening things. There's one question from Elbar Manel. Do you want to unmute yourself and put your camera on, please, if you can?
Yeah, thank you so much. Very nice, very excellent presentation. Thank you so much.
Just echoing slightly.
Can you hear me?
Yes, we can hear you.
You're echoing though. Have you got it on 2 devices?
Hello?
Yeah, we can hear you.
Yeah. Regarding your first case, the lady, she had a...
We lost you, Manal. We lost you.
We can't hear you.
Do you hear me?
Yeah.
Yes.
Yeah, regarding the first case you discussed with urodynamic study, when the lady you give her a B4 because her urodynamic didn't show anything and you just assured her. This lady, if she comes back to you and she's still complaining of leaking when she goes up the hills or she goes to trampoline with her children, and she's very keen for something to do about, do you offer her surgery, or do you ask her to learn how to do intermittent self-catheterization and you give her the advantage of that advantage of going for surgery, or how can you manage her?
Yeah, very good question. So it depends what patient wants. Okay, as I said, urodynamics will not always mimic patient symptoms. So we have facility of doing ambulatory urodynamics where you can see what she's doing with the activity. So we can refer her for ambulatory. Most of the time we do get the answers or do the PAT testing. And if she remains symptomatic, then we will discuss all the options and minor bulkamid. We'll be more comfortable in that case to give her minor operation first bulkamid. But if she's symptomatic and in ambulatory, we have shown that she has got urinary stress incontinence, then we will offer her colpo or sling. Yeah, we will treat her if she wants. Yeah.
Okay, another just one question. I have ladies, they have urodynamics, and the main issue for them, even when they come to the clinic, if they are lying flat during the night, they are fine. When they stand or move, they started to feel they have to go and they leak. But when they see their bladder capacity, it can be up to 700.
Yeah.
And
So what do you think then? If bladder capacity is good, it's unlikely to be diffuse overactivity. So what I think is, because their bladder, it's like lead pipe urethra. So your urethra is open, bladder neck is open. So the urine trickles into the urethra. So they get terrible urgency, but they have weakness of the bladder neck. So likely stress urinary incontinence in these cases, and that's why their bladder capacity is really good. And if proven on urodynamics, we will offer them stress urinary incontinence surgery, even though they are complaining of urgency. But with movement, because the urine trickles into the urethra, they get this terrible urgency.
yeah, because they leak even before you ask them to cough. Once you ask them to move, when you are filling them up, what happens? They started to leak. If you let them stand, they will leak.
Yeah,
Okay.
yeah. So it's likely stress, likely.
Thank you
Okay.
very
Thank you so
much.
much. Thank you.
Okay, Jay, do you want to unmute yourself and ask your question?
Bhavna, yeah, Bhavna, this is not a question. First of all, this is a fantastic presentation. Well done. And this is more like a discussion point. Obviously in aerodynamics, it's more reproducible, the stress incontinence bit, isn't it? More than the DO. Okay, we know that. I had a patient yesterday who is very slim, fit. She's 50s, mid 50s, and she's very keen runner and physically very active. And her main problem is stress incontinence. She's leaking on exercises. So we couldn't find much on the aerodynamic study. Just taking the question from the previous, the lady. So what should we do during the aerodynamics to demonstrate, because sometimes the normal trigger provocative tests, if they can't show the leakage, and the patient is actually saying she's leaking every day quite significantly, and we fill the bladder up almost up to 500, and on coughing she's lying down and she's not leaking at all and bladder is fine. So it's a
Yeah.
disparity between the, and and you and I and the others are, we all sometimes, not always though, because most of the time the stress incontinence is picked up, but on odd occasions when they're not picked up, should we do something and how do we manage?
Yeah, so first of all, I always like to reassure patients, because when it's not reproduced, they get really worried. So I say, look, we believe you have problem and we will get to the bottom of it, because if we don't reassure them, they get very disheartened and start losing faith in us. First of all, I do that. And then we do more tests. So we have to take a specific history. Actually, when do they leak urine? They may not be leaking urine on jumping or coughing. So whenever they leak urine, we have to mimic those symptoms, sometimes squatting. So if we try to mimic that, and again, we say that we are not able to do all the physical activities when they leak urine, so then we may have to do specialized tests like ambulatory or PET testing. And if PET testing shows, then obviously you know that we discuss in our MDT, and then we look their bladder chart and everything, and then we offer them surgeries if they are really struggling.
Thank you.
Thank you. Basma Kareem Bill, do you want to just unmute yourself and ask your question?
Yeah.
Could you turn your camera on?
Thank you. Thank you. Sorry, I'm just not in a position to turn the camera on. Thank you for the talk, Bhawana. It was excellent talk. I've got two questions. First of all, do you ever do stress incontinence surgeries if the patient has got pure SUI only? Because as per the NICE guideline. And my second question is about Bulkamid. What is your experience on using Bulkamid? And is there any special technique you use when you inject the Bulkamid? I find it quite difficult to get that angle when you inject it, and the pressure you have to use to push the Bulkamid, I find it really tricky. So is there any kind of special kind of tricks you have got? Thank you.
So going back to your first question, can you just clarify again? I forgot. Sorry. What did you say? The first one?
Pure SUI symptoms. Do you offer SUI surgery without urodynamics?
So yes, there are different views. You are absolutely right. NICE says if there is pure stress incontinence, you can offer them surgery without doing urodynamics. And I trained in Wales. I did my service spec training in Swansea. So Professor Simon Embry, we used to offer surgery without doing the urodynamics if they have very good history, and we have ruled out DO confidently. But in my current practice, we always do urodynamics, and there are two reasons for it. One is you may miss cough-induced DO. So I showed one of the charts where they cough, and they will always say that I'm leaking just with cough. But when you see there is secondary rise in the diffuser pressure, and if you do stress incontinence surgery, if you do Bulkamid, it's unlikely to work. And if you do slings or any major operation in colpoid suspension, you may actually make her worse by giving them problems. So in my current practice, I almost always do urodynamics. Secondly, litigation and medico-legal aspect is there as well. It does protect us if the cases go to court. We ended up in trouble with TBTs, and we know that we were doing TBTs for some without urodynamics, and we had no proof. So I think it does help to support our diagnosis. So hence I do that, but I know a lot of people who don't. I think Jay wants to make a comment as well. Jay, do you want to make a comment?
Yes, Bhavna, thank you. Yeah, absolutely well said. But on top of it, always remember the voiding function. So if you performing a major surgery which carries the risk of voiding this function, to the extent that the patient may need to do self-catheterization, which may not be acceptable to the patient. So this counseling is extremely important. Now, obviously, we have to acknowledge these days that with the pressures and the waiting times and all, we may not be able to spend that much of time with the patient. And quite often the patients, they do not fill up the questionnaires. So I think it is very important to understand and acknowledge the voiding function of the patient, which is picked up very aptly in the urodynamic test. So although this group of patients with pure stress incontinence is very minimal. Most patients, they have mixed, and particularly the age group we deal with in Derby, our clientels are mostly postmenopausal. So there is a mixed element there. There's a voiding dysfunction element there. So hence, in our unit, we normally offer urodynamics in all patients who are going for any operative treatment for stress incontinence.
I think, thank you. I think I do agree on that. I had a patient recently. What her complaint, she's leaking large amount of urine when she's walking. No urgency symptoms as such. But when I did the urodynamics, actually there is a big detrusor contractions happening, and then she's leaking straight up. But she thinks it's actually happening when she's walking. That's not the case. It's just
that is exactly
such a massive
what Bhavna was
detrusor
trying to
contraction.
make.
Absolutely.
This is the point Bhavna was making.
Regarding second question
absolutely.
for
Thank you.
Bulkamid, so yeah, Bulkamid, I have to be honest, I'm not a big fan of Bulkamid. We do lots of lap colpos and slings here, but if patient wants Bulkamid, we do it. It can be a little bit tricky, so you're quite right. So when you are doing the injection, if you press on the urethra, then you will get it in the right place. And again, without moving the syringe, if you move around, the trocar and get into the position and try to get all 4 I tend to do 4 injections in the same circle, then it's likely to work. And I always counsel patient that this is a minor operation, but success rates are not great. And secondly, sometimes we may have to top it up with the second injection. So yeah, you can attend Bulkamid courses where they teach us on doing on the pigs, which is quite good to practice, because it gives how the tissues and how you inject. Another problem we sometimes have is because the syringe is very tiny, so when you are injecting it, be slow and persistent rather than injecting in a gush, because otherwise it will come out at the end. So pressure and angle has to be right, and slow movement. It's a small procedure. So these are my 2 tips. I don't know whether I've answered your question. Welcome, Ed.
Thank you, Bhavna. Next one, and Nasreen is Nasreen Soliman. Nasreen, lovely to see you on the meeting. Do you want to unmute yourself and put your camera on? Ask your question.
Yeah, likewise. Thank you very much. It was a very good presentation, very comprehensive. So my question is around Bulkamid as well and urodynamics. Would you routinely repeat urodynamics for redo Bulkamids or top-ups?
No. So if I have proven stress incontinence, if you're repeating Bulkamid, I would not repeat urodynamics. No, unless they are going for sling or colpo suspension.
Thank you.
Thank you, Nasreen. Okay. Next, if you next person, I think Suranjan. Do you want to unmute yourself and ask your question?
Oh, hi. Good morning.
Do you want to put your camera on?
My camera is on, but it's not showing my picture for some reason.
Okay, that's fine.
Background. So anyway, Bhavna, I enjoyed your refresher on urodynamics. My question is, I'm Suranjan Koshal from Royal Oldham Hospital, by the way. The question is, what do you do with patients who come to you with pessaries in the vagina for urodynamics?
So we discuss with the patient. As I said, if they have significant prolapse, I do examine them. We tend to offer prolapse surgery first. But if they don't want surgery and they're happy with the pessary, then we leave the pessary in situ, and then we will offer the surgery. Maybe Bulkamid. I'm reluctant to offer slings with significant prolapse because they have voiding dysfunction. So anything stage 2 and beyond, I counsel them that it's better to have the prolapse surgery first and then do the sling. With colpos, we know that anterior wall can be lifted nicely because we do, you can do a little bit lateral and do the paravaginal repairs. So I'm like okay to do colpos, but with significant cystocele, I will not perform slings. Bulkamids, if they want something more permanent, then we do 2-stage surgery. First the prolapse repair and then the sling. But if they're happy to have Bulkamid, then I'll leave the pessary in situ and carry on with the Bulkamid.
My question was, Bhavna, do you actually do the urodynamic study with the pessaries inside the vagina, or do you take them out to do the studies?
So that's what I said, we will discuss with the patient. If she is wanting major surgery, then we do the prolapse repair, then we don't need the pessary there at all. If she wants minor surgery like Bulkamid, then we will do the urodynamics with the pessary in situ, so that because you will need to mimic the symptom with the pessary in situ. Does that answer your question?
Yeah.
Thank you.
Okay. I think somebody else has asked, Bhavna, do you stop antimuscarinics before urodynamics?
So ideally, no. If they have mixed urinary incontinence, we want their mixed urinary incontinence to be treated before we do like any of the stress incontinence procedure. So it depends on the symptoms of the patient. If antimuscarinics are working for them, then obviously we don't need to do urodynamics. If they're not working for them, then we are likely thinking of Botox. In that case, we will stop the anticholinergics and offer urodynamics.
Okay. Are there any other questions at all from anyone? Any other comments, Jay?
see, have you tried using inserts like Contral, Divine, and Euphemia? With Sally. I think Sally, you do a lot of euphemias for us. So yes, we have 1 or 2 patients who like these devices, and we recently, one patient, she didn't want any surgery at all, so we use Euphemia and Contral and Divine. So yes, we do if patient does not want any surgeries.
So what are these devices, sorry, Bhavna, for those who don't know, like myself?
So these are supporting devices in the vagina. They're like pessary. They come in. Yeah. Oh, Jay is showing.
Thanks, Jay. Yeah. Okay. Can you just bring it closer to the screen, Jay? Okay. All right.
So these are just because they will press on the urethra, so they won't leak that much urine. And especially if young women, they're just leaking on trampolining and things, then you can give them. There are certain pessaries as well which come with a knob which will press on the urethra, so you can. These are non like invasive things we can give it to patients.
Fantastic. Jay, any?
Just to end the session, before we end the session, the question going back to what Dr. Ghoshal was trying to say is, should we leave the pessary there if we are doing a urodynamic study on a patient who has got a pessary in? I think what Bhavna was trying to answer is, we in our unit normally we do not we are not in this situation very often, because most of the time the patients who have urodynamic test, they either going for prolapse surgery first if they have pessaries. So very rarely we are in this situation. But if we are, then we do not take the pessary out, because if we take the pessary out, then it not mimic the situation. I just say the thing, but if there's any discussion, anybody wants to do any discussion on this.
I mean, thank you, Joydeep. The reason I was asking, again, the same with us. We don't have many of those cases coming to us as well. But my issue is, if I leave the pessary in, then that affects the bladder in some way. And whether that's a true representation of the bladder function during urodynamics, I'm not sure. But I take your point, both of your points, that we want to reproduce the symptoms as it is now with the pessary in, and probably that's the best approach. I agree.
Yes. Yeah, thank you.
I'm attending.
Okay. Any other comments, Bhavna or Jay? Any other questions from anybody else? Okay, well, that's been a fantastic first session with fantastic speakers there. If we have a 20-minute coffee break now, and if we